But I did want to start with this. Here are our objectives for this module. There's a lot of them. There's 17 of them, okay? The reason I'm giving you these right off the bat is this needs to be your guide for what you're studying through these modules, through this module in particular. If it's an objective that we've been given to, try to meet, that's our goal for this module, it's pretty important, okay? So use this as a study guide, as we go through the different content, subjects here, use that as your guide to study with, okay? So I'll go through these real quick, and also all of these lectures have been posted. At least finished up the third part of this series this morning, so I'll get that posted this afternoon. Okay, so you should have all this stuff. If there's something that doesn't work on on Blackboard or whatever, just let me know. But first objective, we've got assess a client for selected respiratory system alterations. Number 2, develop a nursing care plan to provide care for a client with selected respiratory system alterations. If you've already been to clinical, you've already done that. Okay, so you've made a care plan out for a respiratory patient. You need to be able to tailor that care plan or a care plan for each one of these subjects and concepts that we cover. Also, you need to be able to evaluate the effectiveness of interventions for a client with respiratory system alterations. Explain the anatomy and physiology of the respiratory system. We're about to knock that out in about 5 minutes here. Or not in 5 minutes, but we'll start it in 5 minutes. Number 6, define terms associated with the respiratory system. Number 7, describe diagnostic tests for the respiratory system alterations. Number 8, describe upper respiratory system alterations. Number 9, lower respiratory system alterations. 10, respiratory failure in adult clients. 11, interpret clinical manifestations to determine necessary care for respiratory system alterations. Number 12, describe the process of tracheotomy care, suctioning, and chest PT or physiotherapy. Number 13, describe the pharmacological agents that are. I lost my thought. Where are we at? 13, there you go. For respiratory system alterations. Number 14, describe nutritional considerations for treating respiratory system alterations. Number 15, describe the process for implementing a nursing care plan to treat respiratory system alterations. 16, identify expected outcomes of treatment modalities for respiratory system alterations. And number 17, use critical thinking to prioritize management of care. All right, I kind of saved number 17 for the last, but it's way on up there. What we'll teach you here, a lot of it will be theory, a lot of it will be foundational knowledge and kind of reminder of some of the things you've already learned, but you got to use that knowledge to be able to treat a patient, okay, to be able to provide nursing care to a patient. So our questions are going to be geared toward testing that ability. You got to be able to treat your patients in the various situations. You're not going to have every single pneumonia patient that looks exactly the same, that has the exact same characteristics, that has the exact same signs and symptoms. But you got to be able to recognize some of these differences. You got to be able to recognize when you've got multiple different issues going on, what's important when you walk into the room. Okay, so that's kind of what we're going to hopefully move toward a little bit. All right, so let's take a look, starting out with the anatomy and physiology of the respiratory system. All right, first and foremost, we've got the upper respiratory tract, the nose, sinuses, pharynx, and larynx. Does anybody have an idea on what the upper respiratory system's function is, besides the whole bring in oxygen kind of thing? Okay, there you go. So yeah, it's going to bring in the oxygen or air. We're going to kind of filter out the oxygen aspect of it, but it's going to bring in the air, but it's going to moisten. Anything else? Humidify, filter out bacteria. Absolutely. That's probably the primary system or function of that upper respiratory tract. We're going to bring in and filter. Okay, we're going to humidify and we're going to moisten. Okay. we'll talk about a little later on, if you've got an alteration of this upper respiratory tract, you got to be familiar with these three functions, these three very important functions, because if you have an alteration of that, you've got to, as a nurse, provide that. So a patient with a tracheostomy, what do they eliminate? Or what is eliminated? The upper respiratory tract. So as a nurse, you have to provide care that provides humidification, moisture, okay, also the warming process, also the filtration process, okay. That's why we have sterile technique that we use for suctioning trachs, you know. All right, now we got the lower respiratory tract. This consists of the lower airways. What are the lower airways? I got the bronchioles. All right. Anything else in the lower respiratory airways? Okay. The lungs, yeah. I mean, that's kind of what we all filter down to, those big giant receptacles there. What else? What else with the airways? We got the bronchioles. What connects, what brings the air to the bronchioles? Okay, the trachea. All right. Trachea is still kind of, it's splitting the difference between the upper and lower respiratory tract. But what's the two main stem bronchi? Okay. Now, what about the anatomy of the main stem bronchi is important? Okay, there you go. One's more straight. I know I'm about to lose my integrity mic here, but which one's more straight? Okay, comes down. Which side? To the right. Okay, left side looks a little more like that, right? Different angle. Why is that important to understand? Why is it important to understand that there's a difference in that anatomy? Now, you know, then you got your lung here and there. Okay? What is this airway and the way it's shaped, what difference does that make? Why is it important? Okay, yeah, there's 3 lobes. All right, that's good. Yeah, we got 3 lobes here, right? But what else? If this is more straight, okay, more air, but also what else? More of other stuff. Infection. Because what's more likely to go down that right side along with the air? Well, you got bacteria, you've got foreign bodies. Okay? When the patient aspirates fluid, which side is it more likely to go to? Well, physics. It's going to follow the path of least resistance, right? It's easier to get to that right side, so it's going to go to that right side. That's one of those aspects of the body, one of those anatomy aspects that you just have to be familiar with and understand why that could be important. Okay? So the right side is got a little less degree of angle there. All right? And Chris has already mentioned how many lobes we got on the right side? 3. What about the left side? 2. Okay? Easy way to remember that. We got the heart taking up a space. Okay? Heart's there, so there's not enough room for 3. All right? Probably not exactly accurate, but you get the idea. It's an easy way to remember it. All right? So now, we got the 2 main stem bronchi here that connect to the bronchioles. And then what's at the end of the bronchioles? Alveoli. Why are the alveoli important? That's where gas exchange occurs. If you don't have the alveoli, there's nowhere for the blood to come through and empty off what? CO2. And what is it going to bring in? Oxygen. That gas exchange between oxygen entering the bloodstream and CO2 leaving the bloodstream cannot occur without the alveoli. We'll talk a little bit later about some conditions that, well, they destroy the alveoli. Emphysema, COPD, all that kind of stuff. Okay. All right. So now, the last part of the respiratory tract or respiratory system, not necessarily respiratory tract, is the accessory muscles. Okay. These are important as well. You got the chest, back, abdomen, and diaphragm. If you've got weak muscles in these areas, what happens? There you go. It reduces your ability to bring in air and get rid of what? CO2. Good. All right. Specifically, the diaphragm is going to change the size and pressure of the chest cavity to allow for expansion and contraction of the lungs. You've got to have that process to occur to bring in air so that you can oxygenate the body. All right, let's see. So we've talked about, so what's the main function now? We've talked about a few of these outliers. The main function of the respiratory system is going to be what? Gas exchange. Why is gas exchange important? There you go. Tissue perfusion. What do the cells and tissues have to function? They got to have oxygen. What happens if we don't give the cells and tissues the oxygen they need? They will die. Okay? So, I'd say that's pretty important. All right? So, number one function is supply the body's tissue with oxygen. All cells require oxygen to survive, and the process of providing the body's tissues and cells with oxygen is called tissue perfusion. Okay? Number two, and we talked about it a little bit, but CO2 removal. Removal of our waste. The cell tissue. The waste of cell tissue, metabolism is CO2. We've got to get rid of it. Once returned back to the lungs via the blood, CO2 moves back into the lungs to be exhaled. Okay? Yeah, it's a very important process, and we'll talk about that here in just a few minutes. If we don't remove CO2 like we need to, there's a lot of processes and things that can happen. All right? And this is directly related. Acid-base balance. CO2 is very acidic. The higher the level of CO2, the lower the level of pH, or the pH level. Okay? We'll talk about acid-base in depth here. The body is going to compensate by regulating the respiratory rate and releasing and holding in CO2. So, if the body regulates by removing or holding in CO2, what's it going to do? So if I have a rapid respiratory rate, what is the body trying to do? Blow off CO2. Okay? So if the respiratory rate speeds up to blow off CO2, what's going to happen to the pH, ideally? All right? If the pH goes down when we have CO2 go up, if I have increased respirations to blow off more CO2, so the ideal situation would, we blow off more air, we blow off more CO2, CO2 goes down, what happens to the pH? pH goes up. Okay? That's the way the body compensates. Again, we'll get into that quite a bit here in just a little bit. The next, conditioning of inhaled air. We talked about this a while ago. Inspired air is humidified, warmed, and filtered of any particles or organisms. The upper respiratory tract is a huge piece of that. Okay, and then finally, there are some other functions, including the sense of smell, speech, fluid balance, and temperature control. Now you look at these. These are outliers. These are these secondary functions. Those are pretty important secondary functions, right? I mean, you take away taste, it's not going to be very fun, right? Speech, pretty important. Communication is extremely important. Fluid balance and temperature control, those are pretty important things as well. All right, so now I'm going to give you a video that maybe will describe it a little better than I could of what goes on with the respiratory system. Maybe not. All right, so the role of the respiratory system, well, we're basically trying to, it's a supply and demand kind of thing, okay? We want the supply to meet the demand. What increases the body's demand for oxygen? Okay, CO2, okay. Yeah, that CO2 content is going to make the body through the central nervous system increase respiratory rates. But there you go, activity. Any type of activity, anything that's going to increase the work of the cells. Okay, so you increase the work of the cells, you increase the body's demand for oxygen. All right, what happens if you, this is what happened if I tried to run around the campus a couple times, or probably even down Main Strip here, down by the airport. What's going to happen? I'm out of shape. I'm probably going to be sucking wind out here. Okay, my body needs what? Needs a whole lot more oxygen than it's got. Okay, so increase the activity, you're going to increase the demand for oxygen. Okay, so what has to work harder to meet that demand? Well, the respiratory system, the lungs, the heart, and the blood vessels. Okay, now I know you're thinking this is a respiratory lecture, why are we talking about the heart? Well, it's kind of important, right? The heart and the blood vessels are pivotal to oxygenate the tissues, right? You don't have, well, because what's the function of the heart and the heart and the vessels? There you go. The respiratory system brings it in, but then the circulatory system has to deliver it, right? You can have a breakdown in one or the other, regardless, same outcome. You have decreased tissue perfusion. Okay, so this is what this is going to represent, and we'll show you some alterations here in a minute. Some other things besides just exercise and activity. Yeah, fever. Good. I'll let y'all tell me. Fever, anything else? Infection. Absolutely. What else? What else is going to increase the body's demand for oxygen? Age. Oh yeah, age will definitely have an impact. Smoking. All right. What else? What was that, Chanel? Obesity. Good. I mean, that's right. How would obesity have an impact? You know, you're absolutely right. Why would obesity have an impact on oxygen demand? You got more tissue. You got more cells. The more cells you have in the body, the more they require oxygen. Well, more of that require oxygen. Okay, metabolism. Okay, the endocrine system has a function of this. You know, you increase the metabolic rate, you increase the amount the tissues are working. Right. There you go. So those, you know, these metabolic needs and even malfunctions of the metabolic system may tell the body they need more oxygen than they actually do. All right. So if we, okay, how does a normal healthy person increase oxygen supply? So I'll go and run around the building here and I need more oxygen. What is my body going to do to get that oxygen? Increase respirations. What else? And we said the respiratory and cardiac system are going to be kind of working hand in hand. So we bring in more air and oxygen. What do we have to do with it? We got to pump it faster because we got to get it to the body, because it's not doing any good in the lungs if it just stays there, right? So we got to get to the body. So what's going to happen? How are we going to pump it faster? What's going to be seen? If I go take vital signs, what am I going to see? Heart rate does what? Goes up. Okay? What else is going to happen? With vital signs, even. The heart rate's going up. Blood pressure's going to go up. Okay? The heart's going to work harder to try to get more air and more oxygen. Well, not air. The heart's just worried about the oxygen. But the heart's going to get more oxygen to the tissues, right? Okay? What else? Think about fight or flight. What happens in the fight or flight system? Okay, temperature may go up. But that was one of those things we kind of missed a while ago. Temperature, you think temperature has an impact on oxygen? On oxygen demand? Yeah. As temperature goes up, what happens? Demand goes up. The entire body works harder when the temperature goes up. Okay, that's why y'all all get ornery when you're in the classroom and maybe the air conditioner goes out. You know, your whole body has to work harder. Okay. But when we lack oxygen, our body basically compensates. It moves resources to where they're necessary. Okay? When we're dealing with fight or flight, we're going to try to increase blood pressure and heart rate, and where are we going to really want to oxygenate? Where are we going to shunt that blood to? To the brain? To the vital organs? You know, when you're fighting and flighting, what do you want to do? You want to have weak muscles, you want to have strong muscles? Yeah, skeletal muscles are going to get a lot of resources. Okay? It all goes hand in hand. Okay? You know, the rest and digest stuff, we kind of want to move stuff away from that, right? They don't get the blood supply that they typically would. You shunt to the organs that you need in that fight or flight situation. All right? So, we've got increased demand. What happens if we do not increase the supply? There you go. You increase the demand, so you throw a whole big pile of demand over on this side. If the oxygen supply, you know, you can't throw that up, bring in more oxygen to level it out. That's the body's goal, right? Equilibrium. Everything wants to return back to baseline where everything's just kind of chilling out, nothing's going on. Okay? So if the body cannot meet that oxygen supply, or I'm sorry, that oxygen demand, what happens? Yeah, distress. Distress. You'll still see these signs that, hey, the body wants to keep doing these things to increase supply. But if there's something preventing that from happening, then we got a problem. Because eventually what happens if you deprive the cells of oxygen? They die. Okay? So now you've kind of got, oh, come on. Do I not have that? I had an awesome illustration on here. And for whatever reason, it's not on here. But it's a fat guy on one side and a skinny guy on the other. And the fat guy's the oxygen demand, and the skinny guy's the oxygen. You just have to see it. I'll post it on the thing. But, you know, hopefully it'll illustrate it a little bit for you. If we don't have enough oxygen supply to level it out, we're going to have problems. And that's what we're going to eventually get to talking to. I know right now we're doing the A&P review and all this is stuff that you've seen before, you know, but it's important because you got to know what's normal before you can figure out what's abnormal, right? All right, man, I hate that didn't get on there. In the break, you can come by and you can look at the picture if you want. All right. So now let's talk about these alterations. If we do not meet the body's demand for oxygen, well, this is what we've got to look at. These are factors that impact the respiratory system's ability to meet the body's oxygen demand. So we haven't gotten quite to the alteration yet, but these are some things that can prevent that equilibrium from occurring. Okay? First, we've got level of activity. All right? Regardless of how good a shape you're in, if you just keep running and running and running faster and faster and faster, eventually there's a point where you just can't do it anymore, right? Everybody's going to meet that point. Now, my activity level and your activity level may be different. You know, you may be able to go out and run 15 miles without even really breaking a sweat. I don't know. If I run a mile, I'm probably going to be over here passed out, and you're going to have to be calling an ambulance for me at this point. But that's, you know, that's part of it. Level of activity and your normal baseline of activity. How good a shape are you in? Okay. Also, current and past medical history. Okay? Not just problems with the respiratory system. We talked about a while ago. They're all linked, right? You know, if you have problems in other systems, if you have different issues in other systems, it's going to affect or could have a potential impact on your respiratory function. Okay? Age. Age is a big factor. Okay? Nutritional status, another big factor. Talked about obesity a while ago. Remember, the more tissues you have, the more tissues you have to oxygenate. Okay? The use of cigarettes, cigars, marijuana, or other inhaled substances. Anything you inhale into the body is going to have an impact. You know, some of it we give as medications, has a good impact. Some of it, they're poisons, toxins that we inhale into the body. Well, they cause tissue damage. Okay? Environmental conditions, including pollutants, secondhand smoke. So you may not be planning on puffing on the cigarette, but you're hanging out with somebody that is. You're still inhaling air that has that nicotine in it, and that tobacco pollutants. Okay, animals, etc. All these things are outside sources that can have a huge impact on your lungs and your respiratory system. All right, next, your occupation. How could your occupation have an impact on your respiratory function? There you go. If you work around something that's toxic and you're constantly breathing it in, you know, somebody that doesn't work in that environment, they may be exposed to it once, twice, maybe 3 times, you know, in a extended period of time. But if you're inhaling that every single day, it's going to have a bigger impact, right? The more you're exposed, there you go, asbestos. That's probably the best example we've got. You know, asbestos is and that one of the problems with asbestos is the symptoms do not present themselves for 10, 20, 30, 40 years. You know, you may not even have an idea that you were exposed to it. And that's what we're starting to kind of see now. These people that are coming forward with problems. Yeah. Asbestosis, they didn't know they had it, and now they're experiencing that. Okay. Infection, bacterial, viral, fungal infections, absolutely they're going to alter the respiratory system. Drug use, whether prescribed or illegal. Family history, including genetic risk, and also injury to essential respiratory organs. Okay. You have a car wreck and you damage the lung, you damage the tissue, or you damage the integrity of the lung, it's going to have a significant impact. I mean, pretty self-explanatory there. All right. And we're going to kind of look at some of these in a little greater depth here as we go through. But some of these some of these alterations, some of these factors that could affect the respiratory system, these are some of the things that you'll see. Well, first we'll talk about age-related changes, and then we'll get into that, I guess. Number 1, we've got risk for atelectasis due to alveolar surface decreases. As you get older, the alveoli change a little bit, okay? As you decrease the surface area of the alveoli, you know, you lose that ability to keep it open, all right? And that's what atelectasis is. And what did we say is important about the alveoli? What goes on there? Gas exchange, okay? We want these alveoli to be nice, round, and blown up, basically, okay? If we collapse them, it's called atelectasis. What's the substance that prevents atelectasis from occurring? Does anybody have a guess? Surfactant. There you go. Surfactant is kind of that, well, it's the substance that keeps them open. That's about as good an explanation as I can get you. I guess the example I could give you, if you've ever pulled out, maybe you've got a bag of balloons, okay? They've been sitting in a closet for a long time. You ever had a balloon that just wouldn't blow up because it's kind of stuck together? The same thing. You go to blow it up and it just won't pull apart. Maybe it's been sitting out in the hot sun and melted a little bit, that sort of thing. It just won't blow up. That's what we're talking about there. Surfactant helps keep that open. All right. Next, we've got diminished expiratory effort and efficiency due to changes in lung elasticity. What are the lungs supposed to do when we bring in air? They expand, right? Okay. If they don't expand, what happens? Or they don't expand as much as they need to. You're not bringing in as much air. Okay. You don't bring in as much air, you don't have as much oxygen in that air. So the more flexible the lungs are and the better their ability to expand and contract, the better you're going to be able to oxygenate. Better you're going to be able to bring in air. Okay. All right. Also, number 4, you've got decreased respiratory muscle strength, which results in exercise intolerance and diminished recognition and response to hypoxia and hypercarbia. Muscle strength. Why do muscles matter with the respiratory system? Well, That's what's allowing you to breathe, right? You got to have the muscles attached to these respiratory organs to be able to bring in. For the diaphragm to be able to allow the lungs to expand, you got to have these muscles there to be able to allow that process to occur. All right, number 5, we've got vocal changes due to physiologic changes to the muscles supporting the vocal cords and the larynx. As we age, our voices will change. Okay, just part of it. You know, you've probably heard, you know, you've been in a hospital, or you've been in maybe you've got a family member. A female voice sometimes starts to change into where it's got a deeper tone to it. It's more scratchy. Male voices, you know, they've got the same characteristics. As you change, that just occurs due to this. You've got these vocal cord changes, okay, and the muscle changes that support those vocal cords. Number 6, confusion. Due to the increased risk for hypoxia and increased resistance to blood flow through the pulmonary vascular system. All right, confusion. Remember this one. Confusion is very, very important, because if you've got an elderly patient that's confused, do not blow it off just because they've got Alzheimer's. If there's a significant acute change in that patient's level of orientation, okay, we got to figure out what the problem is, because it could be a respiratory problem. Why would a respiratory problem cause a neurological change? There you go. If we diminish or deprive the oxygen supply, you know, to the brain, well, that's not a good thing, right? Those are the tissues you definitely don't want to lose, right? So confusion, usually it's a later sign. Sometimes with elderly people, they've got so much going on, they don't even recognize problems that are just an everyday part of their life. If I go run around the building and I can't get enough oxygen, I'm probably going to feel it, right? Because it's a significant change from where I'm standing right now. An elderly patient, they already feel awful. They've already got some of these things going on, some of these other issues, these other body system alterations, where they don't recognize these significant changes. They don't pick up on it as easy. So the confusion is a huge aspect of that. You've got to be able to recognize confusion and at least experiment with it. You got a patient that you've been caring for all day, and you know they were a little out of it, but you walked in, they knew their name, they knew their birthday, they knew where they were, and then suddenly, toward the end of the shift, they don't know who they are or who you are or what you've been doing and you know where they are. That's significant. At least put a pulse ox on them. You know, at least evaluate that respiratory system to determine if it is related to oxygenation. Okay, does that make sense? You know, that's important there for the elderly. So number 7, we got skeletal changes resulting from osteoporosis. Can lead to increases in the AP diameter, progressive kyphoscoliosis, and also diminished chest wall compliance, elasticity. With scoliosis, that's the big problem. You know, you think about adolescent scoliosis and the changes to the spine. Yes, that's, you know, from a cosmetic standpoint, that's kind of what they always look for. But the problem is, if you do not treat that scoliosis, it's going to alter the chest cavity. It's going to alter the way that person, that adolescent, can bring in oxygen. Same thing here. As patients, as they age, as people age, the structure of the skeletal system within the chest makes it difficult for them to be able to breathe in and out. Okay, so just part of it. They lose that ability to bring in oxygen and then also exhale the CO2. All right, so now our assessment of the respiratory system. Some of the respiratory problems we're going to look for: cough. You want to ask about the occurrence. You know, does the cough occur in relation to something else? Yeah, every time I start walking to the mailbox, I start coughing. Yeah, that's maybe a respiratory issue, but also you learned a couple weeks ago it may be a heart issue too, right? With CHF. But you want to ask about the occurrence. Also ask about, you know, do they have sputum present? When they cough, are they coughing something up? And then if they're coughing something up, what color is it? It's kind of your typical thing there. What color is it? How much is it? You know, how much sputum do you get out? and then also kind of about the occurrence, but a relation to activity. It's pretty common for patients to wake up and have to cough, especially as they get older. You want to know the time of day. You want to know, does it occur in relation to meals? Why would you possibly have a cough in relation to meals? Choking? Okay. Yeah. Are they aspirating? All right. What else? Not going down the right way. It's not going down completely. Okay. There may be something in your, esophagus that's kind of keeping stuff up there. All right. What about acid reflux? It's pretty common too, right? You have a little acid reflux after you eat, and they have a little cough with it. Very common. All right. Next, we've got chest pain. You want to determine the type, onset, potentiating factors, and then relation to the breathing cycle. Okay, very important. Yeah, it may be a heart issue, and if it is, we need to figure it out. We need to figure out what's going on. It also could be a respiratory issue. The lungs are in the same cavity as the heart. They're still in the chest, right? So if you have maybe inspiratory pain, you have pain on exhalation, you got to figure out when it is, and then we'll talk in a minute about some of the things that can be causing that pain. And then finally, we've got dyspnea. What's dyspnea? Difficulty breathing, shortness of breath. They just can't catch their breath. Okay. Good. All right. Specifically with dyspnea, we've got 5 categories here, and this would categorize a patient's level or severity of the dyspnea. All right. Class 1, you got normal activity, no restrictions, everything's fine. Okay. Dyspnea only occurs in more than normal or strenuous exertion. I'm hoping I'm still in class 1, and when I run around the building, just a little bit of discomfort, a little bit of shortness of breath. Class 2 is when you're moving into independent and essential ADLs, or restricted in some activities. Dyspneic on climbing stairs or on walking on an incline, but not on level walking. Kind of scares me, because the other day the elevator was out and had to walk up 3 flights of stairs, and it wasn't fun. So, that's hopefully I'm not moving into stage 2. I need to start working out, I guess. Class 3, you've got dyspnea commonly occurs during usual activities, such as showering and dressing. How is that going to impact a patient's overall status? Yeah, I mean, psychologically there's going to be an impact. If they have to have help getting a shower, if they have to have help getting dressed, for one, they may just not do it. If a patient has trouble taking a shower, or has trouble changing clothes, sometimes they're a little less likely to do that. That could impact their overall health and well-being, right? But the patient can manage without assistance from others. Okay, so, they don't necessarily have to have help then. I stand corrected. They just have trouble with it. So they go and take a shower and they get out of breath. They're still less likely to do that activity. Not dyspneic at rest, but they can walk for more than a city block at their own pace, but cannot keep up with others of their own age. May stop to catch a breath partway up a flight of stairs. It's probably not employable in any occupation. Getting tough, right? So what is that last sentence there? How is that going to impact the patient? Now we're moving into psychosocial stuff, right? Not just psychological. Now we're moving into psychosocial. You've got an alteration in the patient's daily life, their overall dynamics of the family. How well can they get through the day? Pretty significant. Once we start getting into class 3, these are the classifications that will significantly alter the patient's daily life. All right. Class 4. Even more, we've got dyspnea produces dependence on help in some essential ADLs, such as dressing and bathing. So now this is the one that has to have some help with taking a bath. They're not usually dyspneic at rest, but dyspneic on minimal exertion. They must pause on climbing one flight, walking more than 100 yards, or dressing. They're often restricted to home if the patient lives alone and has minimal or no activities outside of the home. Okay. significant psychological impacts here. And then class 5, they're entirely restricted to home, often limited to a bed or chair, dyspneic at rest, and dependent on help for most needs. It's a huge debilitating manifestation of respiratory issues. All right, some other abnormal findings. We're looking at the mouth, nose, and sinuses. What are we going to look for that would tell us that there's something wrong with the mouth, nose, or sinus? Okay, dryness. Drainage, absolutely. What else? Let me do that one. Deviated septum, absolutely. Any others? When you take that pen light in the clinical setting and you shine it into somebody's mouth and their nose, what are you looking for? Any kind of obstructions. Okay, what else? Gag reflex, yeah. Yeah. Any alterations in that normal, well, the assessment of the head. Okay? But a big one, obstructions. If you have something obstructing, say you've got some kind of obstruction in the nasal passage, what are you doing? Well, you're reducing the ability you have to bring in oxygen, right? Any kind of obstruction. So if the other side's not, well, if it's not good and clear and bringing in double time, what the other is, you've lost something there, okay? You're also looking for, well, we said the redness, swelling, ulcerations, rash, fungal lesions, or fungal infections. What type of fungal infection do we commonly see? Thrush, absolutely. All right. Pale discoloration of the oral mucosa. Okay. What would that indicate? You've got paleness of the oral mucosa. Could be dehydration. Could be diminished oxygenation. Anytime you got pale discoloration to some of the mucous membranes. We'll talk, well, we won't talk. Used to saying that. In the endocrine system, you'll look at some of the endocrine system issues. You can't really, there's not a lot of external factors that will impact, no, never mind. There are some endocrine issues that you'll talk about that can impact the skin, but if it's impacting the oral mucosa, you know that it's a systemic issue. And I'll leave it at that. Yeah. You can get into that with whoever's teaching the endocrine stuff, Ms. Powell. All right. The trachea, pharynx, and larynx. We're looking for any kind of palpable nodules, masses, tenderness, bruising, swelling. These vocal changes we talked about a little earlier. You're looking for that. You want to see what's going on with these types of issues. Okay. Really commonly, or I guess that didn't sound right, did it? Really commonly. All right, but commonly you'll see deviations. Well, for one, we're going to talk about in pneumothorax, a tracheal deviation is really important. But if you've got masses or you've got tenderness to the trachea, a lot of times that's a thyroid issue. Kind of going back to that endocrine stuff. So you got to be aware of that. All right. I know we're talking about respiratory, but you can't keep it all bottled up in respiratory because it's all connected, right? And then the lungs and thorax, you're going to look for any discolorations, masses, lesions. You want to see what? When I look at the patient, I walk in, I'm going to assess their breathing. What am I looking for? Chest expansion, and that's the big word there, bilaterally. Okay? If we've got two of something on both sides, we want it to do the same thing, right? If not, there's some kind of alteration to one side or the other. All right. So we want the chest, we want it to expand, fill up with air. We want it to go back down equally. All right. Specifically in this pneumothorax thing we're going to talk about in a minute, you'll see that as a big issue. Okay. You're also looking for AP diameter. So AP to two lateral diameter should be 1 to 1.5. All right, what am I talking about with AP diameter? AP diameter. This is, if you looked at me from the side, anterior, posterior diameter. Okay? What's the distance from my front to my back? Okay? To lateral. Lateral, side to side. Okay? That should be 1 to 1.5. So 1 to 1.5. I should have 1.5 greater distance from here to here than I do from here to here. Does that make sense? Okay. So 1 to 1.5. That's a huge indicator of chronic respiratory issues. What happens when you go to the gym? Okay, say I go to the gym over here and I work out just my arm. What's going to happen? 5 days a week I go over there for 2 hours a day and I do nothing but this with some big weights. And I'm going to look weird because bilaterally it's going to look off, right? But what's going to happen to this muscle? That muscle is going to get bigger. Okay? So the respiratory system, if I have an alteration in my respiratory system, if I'm not oxygenating, if I'm trying to work to meet that demand for oxygen, what happens? What muscles am I going to build up? There you go. The chest muscles. All right, those are the big ones. All of these respiratory muscles we talked about earlier, they're going to get bigger because they're having to work double time, and that's really all they're working because they can't really do anything else. These patients can't necessarily do anything else because they're struggling to breathe. If they sit there all day and they're working to breathe, they are building up these chest wall muscles. So what changes? The AP diameter. Okay? These chest wall muscles are going to get bigger and bigger and bigger and bigger and bigger. Okay? So this AP diameter is going to grow. Okay, does that make sense? And keep getting bigger and bigger because we're working those muscles. All right. Vocal tactile fremitus. What's fremitus? I got an idea on that. Fremitus. You ever heard of that? Vibrations. Vibrations. Fremitus is vibrations. Okay. So in your assessment, your comprehensive health assessment that you're doing, and I don't know if this is something that y'all have got included in that, but if you wanted to assess for fremitus, how would you do that? There you go. I heard a 99 over here. There you go. 99. You're going to take the palms of your hands, you're going to put them here, or you can put them on the back, and ask the patient to do what? Say 99. There you go. If you have, as they speak, you feel vibrations, that's an abnormal finding. Now, I'm kind of doing it right now, and I feel it too. It's going to be very pronounced, all right? And I hope I'm not in respiratory compromise here, but you're going to feel pronounced vibrations. What that indicates is that the density of that chest wall cavity has increased. All right, you're going to see it a lot with pneumonia. You've got a mass or anything like that. It's going to increase that chest wall or that chest cavity. Yeah, so don't freak out because I'm doing it too. Hopefully everybody else is feeling that fremitus a little bit. I'm talking about pronounced fremitus. Okay, lots of vibrations. Also auscultation. What's important about auscultation? Well, that's the way we can audibly hear any issues that are involved with that inspiration and expiration process, right? Okay, pretty important. Okay, and then let's see. The last thing is going to be some of these, fatigue and activity intolerance. You know, we want to assess. Okay, how can you assess? You walk into the room and you're assessing a patient's activity tolerance. What's a good, quick, easy indicator of whether they're able to tolerate low-level activity? Talking. You walk in and say, hey, how are you doing? What happens? Hopefully they're going to respond to you, but if they get out of breath or they're really, really short with their answers, try to give them a question that makes them expand on that a little bit. Give them a question where they have to give you more than just a one-word answer. And you'll see real quick, if they cannot tolerate speaking a sentence, then it's a huge alteration. And that means they're not able to get enough oxygen in to even communicate, to even be able to speak. All right, some of the big signs of respiratory inadequacy. we've got clubbing of the fingers, and this is chronic. This is not something that's going to happen overnight. Okay, you've seen the chronic patients with the clubbing of the fingers. I wish I had a picture. I don't think I do. But y'all know what I'm talking about, right? The big bubble end almost looks like a ball on the end of their finger. That's the clubbing. I'm sorry. There you go. Yeah, it looks like they got a bunch of balls on the end of their fingers there. All right. Pallor and cyanosis. Okay, what's pallor and cyanosis? Paleness and even bluish discoloration, the cyanosis part. Okay. Weight loss, loss of muscle mass, also thinning of the arms and legs. Now, we've just said these patients are going to get big, bulky chest cavity, well, chest muscles, right? But then they're going to have little tiny legs, really thin legs and arms. Okay, that's a telltale sign of chronic respiratory insufficiency. The only thing that's building up is the chest. All right, and then also you've got hypertrophy of the chest and neck, and that's the same thing. Everything's building up. The neck muscles build up. Okay, but all the other stuff is being, deprived of not only oxygen but also nutrients. Okay. All right. You want to take a break? I can tell. All right. Take a quick break. It's 10 o'clock. How long do y'all know when to take a break? And don't tell me an hour. About 10, 15 minutes? Yeah, I'm sure he does. Let's do 10, 15. All right. So I know we got a lot to do. All right, so here's the videos that we tried earlier. Didn't quite get, but hopefully.
The respiratory system is the system of the body that deals with breathing. When we breathe, the body inhales the oxygen that it needs and exhales the carbon dioxide that it doesn't need. Air entering the nose is contaminated with irritants such as air pollutants, dust, pollen, and bacteria. A unique mechanism in the body warms and humidifies the air that we breathe and removes the majority of contaminants before the air reaches the alveoli in the lungs. Once air enters the nasal passage, it passes over the highly specialized respiratory mucosa. Almost the entire lining of the respiratory tract is lined with mucous membrane that is composed of ciliated pseudostratified epithelium. The respiratory mucosa is rich in goblet cells that produce mucus. This moist, sticky secretion acts much like flypaper to trap entering irritants and prevent them from going deeper in the respiratory tract. The removal of contaminants is further assisted by tiny hair-like cilia on the surface of the mucosa that sweep inhaled contaminants in the mucus secretions upward toward the pharynx to eventually be removed.
What? Yeah, coughing. Yeah, that would be the expectoration.
A very thin membrane separates the air in the alveoli from the blood in the surrounding capillaries and is the site of gas exchange in the lungs. Each alveolus is continually supplied with fresh air. Surrounding each alveolus is a network of capillaries, arranged so that air within the alveoli is separated from the blood in the capillaries by the thin respiratory membrane. The wall of the alveolus is composed of surfactant, epithelial cells, and basement membrane. The surfactant lines the inner surface of the alveolar wall along with a thick layer of fluid. The fluid keeps the alveolar surface moist. When air leaves the alveolus during expiration, however, the water exerts a strong force that can cause alveolar walls to be drawn together and collapse. Surfactant prevents this collapse and allows the alveolus to inflate with ease after expiration. Between the alveolus and the wall of the capillary is a very small space with interstitial fluid. On the other side of the interstitial space is the wall of a pulmonary capillary, which is made up of a basement membrane and endothelial cells. The respiratory membrane consists of the layers through which the gases must travel to get into or out of the alveoli. Carbon dioxide and oxygen diffuse across this tiny membrane, allowing the exchange of gases to flow back and forth smoothly.
All right, so let's move on. All right, so now we'll get back to where we were, but the respiratory system, we'll kind of continue with our assessment here. The big part of this that I want you to be aware of, and I know this is still review. I mean, this is stuff that you've gone through, but it's pretty important. Looking at this, okay, this view here is a posterior view. That's looking at your back, okay? This is looking at your front. If I only assess a patient's back, if I only do auscultation of the back, am I actually listening to every lung field? No. Because how many lobes did we say we had on that right side? Okay. If you look at the back, you can assess bilaterally, you're doing everything you're supposed to, but there's no way for you to assess the third lobe on the right side if you only assess from the back. Okay? So it's very important. You're assessing bilaterally, bilateral landmarks, okay? But you also want to make sure that you're assessing from the side and also from the front, okay? It's very, very important because you're not even going to get this third lobe over here unless you assess either from the side or at the very bottom anteriorly. Okay, does that make sense? Very important. Some of the adventitious breath sounds that you'll go through, you need to be familiar with these. You need to know kind of what does this adventitious breath sound indicate? You know, what are some of the problems that could be occurring as a result of that, or in relation to that? I'm not going to go through all this. We kind of need to start moving along a little bit. And know this is still review. Just be familiar with this chart, okay? It's in the slides, but it's also in your book. All right. Now, the next thing we're going to talk about, the psychosocial impact of respiratory alterations. We talked about it a little bit. You know, if you have a patient that, well, their life has changed as a result of not being able to breathe with activity. It's pretty significant. You know, there could be family dynamic changes, there could be social changes. Patient that used to be active, used to be healthy, is now no longer even able to leave the house. That's a huge problem, right? Also, think about the psychological impact of just an acute, you know, round of dyspnea. You know, you've got an acute episode of dyspnea. What happens if, okay, you're swimming, somebody pulls you underwater? Okay, you can't breathe. How do you react? You start to panic. Okay, you're scared, you're panicked, and what happens? You're fighting, right? The fight or flight response goes into effect, right? You're doing everything you can to get up to air. It's the same thing here. If you go into Now the chronic patient, a lot of times they'll almost get used to not having that, that extra oxygen or the oxygen that they need. But an acute episode patient that just suddenly cannot breathe, they're scared out of their mind. The same response you would have if somebody pulled you underwater and you couldn't get to the top to breathe, they're going to have that same panicked look. So when you walk into the room and they're having an acute episode of respiratory distress and you see that just pure look of fear in their eyes, you know, hey, we got to get something done quick. Okay, put yourself back in that situation and imagine how you would feel if you just completely were deprived of the ability to breathe. Okay. But along with this, we've got to discuss with the patient some of these fears. We've got to discuss some of the coping mechanisms, back to the life alterations. This needs to be part of your care as a nurse. You can't just completely disregard this and say, well, I'm just going to give them some oxygen and pulse ox, and then, we're going to let them, hopefully improve a little bit. You got to figure out, okay, what dynamics are going on, what fears do they have, and how is it impacting their life. Okay. Next, we've got some diagnostic testing. These are the tests that we use to diagnose and determine the level of respiratory distress that is occurring. First, we've got blood studies. Okay. Why do we look at the blood? Why is it important to look at the blood when we're trying to determine respiratory malfunction? There you go. We're looking at oxygen content in the blood. Like we said before, that's the transport mechanism. We can breathe in perfectly. Our respiratory system can be bringing in the perfect amount of oxygen for our demand. We could be meeting that demand from the respiratory system's aspect, but if we don't have the ability to transport that to the cells, it's going to be, a moot point. Okay. So we want to assess not only the cardiac system and the cardiac system's ability to transport that oxygen, but also it's a good indicator if we have diminished oxygenation going on in the actual blood supply, then they can increase the heart rate, they can increase the blood pressure all day, but we're still not getting the adequate amount of oxygen that we need. Some of the things we'll look at, CBCs, okay, but probably the most important is going to be your ABG levels, okay. This is a pretty good diagnostic testing summary here, I guess, of some of the things we'll look at from the blood supply. You've got the CBCs. This is what it's going to evaluate. The big one here is hemoglobin. What's hemoglobin? There you go. That's the component of the blood where the oxygen binds. Okay. So if we have a reduced number of hemoglobin in the blood, what happens? There you go. We have blood that's being transported to the tissues with diminished supplies of oxygen. Okay? You can bring in more oxygen, but if you have reduced levels of hemoglobin, it can't bind to anything. Okay? It's not going to be transported to the tissues. So if you've got a patient that, you walk into the room, they're struggling to breathe, you've got some respiratory distress going on, you throw in an oxygen sat, pulse ox, they're 100% on room air. Okay, why is this patient telling me they can't breathe? They're 100%. Well, it may not be a respiratory issue, it may be that circulatory issue. Okay, they may have diminished blood supply or blood counts that prevent the transport process from occurring. Does that make sense? You gotta put both together. Okay, so we're looking at hemoglobin levels. We're looking at hematocrit. We're also looking at white counts. What is the white count going to indicate? Infection. Okay, there you go. If you have an infection in the lungs, in the respiratory system, you're going to see the white counts go up. Okay, hopefully. If you actually have the infection, you want the white counts to go up, because what is that doing? Fighting it off. All right, then you've also got the differentials, okay? The actual numbers and percentages of those white counts. The neutrophils, the eosinophils, basophils, lymphocytes, and then also your monocytes. And I'll let you read through all that. Now we're going to look at the ABG levels, okay? ABG levels, and I know you probably freak out some when you see this. How much have y'all actually done on ABG levels? Not much or none? Okay, that's fine. We'll get to it. We'll get it figured out here. But the ABG level, what is an ABG? Arterial blood gas. So arterial blood gas, what are we getting the blood sample from? The artery. There you go. We are evaluating the arterial blood supply, the arterial blood components, to determine how much oxygen is in that arterial blood, what is the pH of that arterial blood, what's the CO2 level in that arterial blood, and then also the bicarb levels. Okay, and then and then we've also got the saturation of hemoglobin, the percentage. And this is not like putting on a pulse ox. Okay, what are we measuring on a pulse ox? Oxygen saturation of what? It's the capillary. Okay, we're looking at the capillary here. Artery to capillary is a big difference. Okay, now the levels are going to be pretty similar. Still 95 to 100%. Capillary pulse ox percentage can be a little lower, somewhat. We still like to see 95 to 100%, right? But the arterial blood definitely needs to be 95 to 100%. Okay. Decreased levels are going to indicate possible impaired ability of the hemoglobin to release oxygen to the tissues. Okay. All right. So let's look at. Well, we didn't get all of it here. I'll go back just to the sputum. Okay. The sputum is very important, especially in the respiratory system. This is our ability to evaluate not only for bacteria, organisms, things of that nature, but also it helps us to identify abnormal cells in the lungs as well. Okay, so cancer, allergy, these are things that can also be picked up. We can see some of the things that through that sputum test, sputum smears that allow us to kind of do some further research, further testing, maybe do an X-ray, chest X-ray, to evaluate for some of these abnormalities. Imaging is also important. Okay, we want to see and visualize the structure and function of the lungs and the airways. Okay, so we can also observe pathologic changes to the respiratory system. We're looking at all the different things that that inspiration and expiration process, and also looking for any abnormalities and masses that may be there as well. Ventilation and perfusion scans. This is evaluating, or it's basically our visualization of that circulatory system. We want to see how well the oxygen is coming in, or I'm sorry, the blood supply is coming in, and that gas exchange is occurring. Okay, and then finally our pulse oximetry. This is our non-invasive test. You can walk in and put a pulse ox probe on anybody. Okay, it's non-invasive. It's not going to hurt them. This is a way to evaluate that oxygen saturation without actually going in and sticking for an arc stick, because those arc sticks are not fun for the patient. I've seen. I don't know. I haven't felt it, but I would imagine. What I've been told is it's like a peripheral IV times 100. A lot of pain there. All right. So now let's look at our ABG levels. I know this is something that y'all all kind of freak out a little bit about. But first thing we need to look at is, all right, these are the three most important indicators that you'll look at: pH, CO2, and bicarb. Okay, this tells us a whole lot about the condition of the patient's respiratory system. Okay, does anybody know what the normal pH of the blood is? There you go, 7.35 to 7.45. Okay, that's your normal, typical arterial pH. Okay, so we want to see arterial pH 7.35 to 7.45. All right. Now, we're setting up a system here for kind of evaluating the levels. All right. We're looking at acidosis and alkalosis. Okay. I don't know how much you're familiar with that, but that's the the terms that we're going to use for determining what the pH is. If the pH is acidic, it's going to be on the 7.35 side of that normal range. Okay? If the pH is basic, it's going to be on the 7.45 side of that range. 7.40 is kind of neutral. It's right in the middle. Okay? But if you've got a 7.39, it's more acidic. If you've got a 7.41, it's more basic. All right? So that's the first component. Determining acidosis versus alkalosis. Okay? So we've got to determine our pH. Which side is it on? And if it's an alteration, if it's altered, then we've got two components or two processes that could be the result. All right? It could be a respiratory issue or a metabolic issue that causes that pH to move abnormally in either direction. Okay? First things first, you want to figure out, okay, what's my pH? Is it normal? Then we're good. If it's abnormal, then we gotta figure out what's causing the problem. All right. So the best way to do this is you determine, like we said, 7.35, 7.45, acidosis versus alkalosis. Okay. The next thing I want you to do, you're going to look at the CO2 level. Does anybody know what the normal CO2 level is? There you go. It's easy to remember. If you can remember 7.35 and 7.45, you can knock out CO2 real easy because you just drop the 7 and the decimal point. All right? So a normal CO2 level is 35 to 45. Okay? All right. Now, this is where it gets a little bit trickier. What did we say is more acidic? High levels of CO2 or low levels of CO2? High levels. So if the CO2 goes up, the blood becomes more acidic. All right. So our 45 is going to go on the CO2 side. Okay. The higher the CO2, the more acidic the patient is. All right. Now the opposite's true on the basic side. Okay. The less CO2 we have, or the fewer numbers, or whatever, the lower the CO2 level is, the more basic we are. Okay. So if I had a respiratory alteration of the pH, okay, so if I had something from the respiratory system that caused the pH to become more acidic, what's happening? All right, so if I've got my pH here, and my pH level is 7.32. Okay, so my pH is 7.32, and it's a respiratory problem. What happened to my CO2?
Went up.
So if it's a respiratory problem that caused the pH to go down, then that means my CO2 went up. Does that make sense? So if the alteration and the CO2 went up, it's going to be greater than 45, so 48. Okay? So if I've got a pH of 7.32 and a CO2 of 48, this is the cause of the pH to go up. Okay? So it's a respiratory problem. Well, basically it's a respiratory acidosis problem. Does that make sense? All right. Okay. Now, there's three components to the ABG level, though, right? This bicarb, remember when we talked about the seesaw? What's the body doing? It's trying to get back to homeostasis, right? Well, homeostasis for the blood is 7.35 to 7.45. So this third unit, third measurement, bicarb, it's going to sense that the pH is off, and it's going to try to make some alterations. Okay? So now, my normal bicarb. Does anybody have a guess on normal bicarb? All right, 21 to 28. Now, 22 to 26 is what I've always gone with. That's what we've always used. That's what I was taught. That's what we've always used. Looking at the book, it's 21 to 28. So that's what we're going with. Okay. 21 to 28 is your normal bicarb level. Okay. I don't know why they changed it. I guess they figured out bicarb needs to be a little lower. I don't know. Well, lower and higher. But the bicarb is 21 to 28. Okay. So, if the bicarb senses the pH is acidic, how could the bicarb make the pH more basic? Well, bicarb is basic. It's an alkalinic substance or whatever. Okay? So bicarb is alkalinic. If it goes up, the pH goes to the alkalinic side. Okay? So in our tic-tac-toe board here, we're going to put less than 21 as acidic, more than 28 as alkalinic. Okay? And I know you're starting to get bogged down. Just hang with me, okay? I promise. This bicarb is going to start moving to the more alkalinic side. So what's it going to do? It's going to go up. Okay? So it's going to start increasing to make it, the pH, more alkalinic so that it can balance out that seesaw. Remember the seesaw we had over here with the big guy? Well, you didn't see it. I'm sorry. You didn't see it. Just imagine the big guy laying on one side and the little guy on the other. Well, the bicarb is going to go try to jump on the side with the little guy. Kind of balance it out. Okay? Does that make sense? So it's going up to balance out that seesaw. Because the body wants to keep it right here, even keel, right? So, if I'm going to evaluate an ABG level, okay, so let's just say, I think I've actually got an example, hopefully. If not, I'll make one up. Let's just do this. All right. Say I've got a pH of 7.42. I've got a CO2 of 40. And then we've got a bicarb of oh, hang on. Yeah, that'll work. 34 will work. All right. So here's what we got to do, okay? You've got to first figure out, and take your little tic-tac-toe board here. First thing you want to do is put a mark in where the pH is, okay? So in this case, we've got a pH of 7.42. Where would your mark go? Okay? Well, we didn't do it alterate. I want it to be off. How about this? Let's do 7.48. That's what I meant to do. So 7.48. Now where's 7.48? Alkalosis. All right? So on your tic-tac-toe board, put a check over on the alkalosis side. So right here, I don't think it's going to let me make a mark, but that's where you'd want to do it, okay? All right? So your first mark is on alkalosis, on the pH side, okay? Now let's go to our CO2. Is our CO2 acidic, normal, or alkalosis? It's normal, okay? So you can put a mark here on normal. Okay? Now let's look at our bicarb. Where's our bicarb? We've got 34. Is our bicarb acidic, normal, or alkalinic? Alright, so it's also alkalinic or basic. I don't know if it's the correct term to say alkalinic, but you got the drift. Alright? Now you want to line them up. And in this method, you don't have to have 3 in a row for tic-tac-toe. You want to get 2 in a row. Alright? So you take your pH and determine which one lines up with the pH. So in this case, we've got a pH that's alkalinic. Which other number is alkalinic? Bicarb. Okay? So 7.48 we know is alkalosis, right? Now you've got to look at, is the problem respiratory or is it metabolic? It's metabolic. So there you go. That's the first part of it. Okay? So step 1, figure out your pH, acidic or alkalinic. 2, figure out whether it's a respiratory problem or a metabolic problem if there's an issue. And the third thing is you're going to figure out whether that third number or that third unit has started to move. Okay? If it started... Yes. Yeah, and the question was, is it metabolic because it's not dealing with CO2? And yes, in a nutshell, because it's not dealing with the respiratory system. Okay? Because the CO2 is normal. Respiratory, absolutely. Yeah, if the CO2 is the issue, it's respiratory. If it's the bicarb that's the issue, it's metabolic. 100% of the time. And we haven't talked yet about what causes that from the metabolic system. We'll get into that a little later. But that's the first step. Figure out your pH, then figure out where the problem is if it's abnormal. If it's not abnormal, then you're done. But if it's abnormal, then you got to figure out where the issue is. The third step is going to be figuring out whether compensation has begun to occur. Okay? In this case, we've got a CO2 of 40. Has CO2 moved either direction to try to bring this pH back down? No. So in this scenario, is it going to be uncompensated or compensated? Uncompensated. So look at your third unit. If your third unit has moved, then you've got to look at whether it's compensated or not. Okay? Now, here's what direction. Okay, so now we're going to go back to our CO2. If the CO2 decided there's an abnormality and I want to move to bring the pH down, what direction is the CO2 going to move? CO2 is going to go up, because up means the CO2 is making the pH do what? Become more acidic. All right, so now, let's say our pH now, it's recognized the problem, it's not uncompensated anymore. Now let's say it's 48. Okay, is 48 acidic, normal, or alkalinic for a CO2? Acidic. Okay. All right. So now put that on your tic-tac-toe board. It's going to go on the far left side, right? Because it's acidic. All right. So now this has moved to acidic. And let's look at our pH. Now our pH is 46, 7.46. Okay. So pH 7.46, CO2 is 48, bicarb is 34. Okay. Now, what do we still have? What is the pH? Is it still normal, acidic, or alkalinic? It's still alkalinic. Okay. Now let's look at the CO2. Is it acidic, normal, or alkalinic? It's acidic. Okay. Now let's look at the bicarb. Is it acidic, normal, or alkalinic? It's still alkalinic. Okay. Which two line up? The pH and what? Bicarb. So we still have metabolic alkalosis. Okay. But now, let's figure out compensation. What's the third part? All right. Has this number moved to abnormal? Yes. So we have some kind of compensation that's occurring, right? All right. So it's compensated. We have compensated metabolic acidosis or alkalosis, but the problem is the pH normal? If the pH is normal, we have full compensation. But if the pH is abnormal, we have partial compensation. Okay? So there you go. Partial compensation. That's how you figure out. Now, okay. So now our next scenario, let's look at our pH is now 7.44. Okay. All right, so now we've got a pH of 7.44. Okay. It's not. That's the key. If it was normal, then it would be fully compensated. Okay. Yeah. But that's a good point. If the pH is still abnormal, but you've got the other two numbers are abnormal, then you've got some kind of compensation going on. You just got to figure out where the problem is. That's why you have to line them up. If you line up the pH with whatever that problem is, then you look for the third one that's in the opposite direction. That's your compensation point. Okay, so partial compensation is when the pH, well, the pH is still abnormal, but the third number, so in this case, you had metabolic alkalosis. So the bicarb is the problem. The CO2 moved to an abnormal range to compensate, but it just hasn't quite got the job done. So it's partial compensation. Does that make sense? So yeah, that third number is moving, and it's moving in a direction to bring the pH back to normal. It just hasn't quite got there yet. Now what do we have? We've got a pH of 7.44. Is that normal, acidotic, or alkalinic? It's normal. We've got a 50 on our CO2. Is that acidotic, normal, or alkalinic? Acidotic. Okay. And we've got a a bicarb that's now 34, still 34. Is that acidotic, normal, or alkalinic? Alkalinic. Okay. So now we got to figure out. Okay, and if you're looking at this fresh, now you've seen the movement, so it's a little easier. If you just walk in and you're looking at this number and you're like, okay, these three numbers, what is it? Well, pH, is it on the acidic or alkalinic side? All right. It's normal. Make you a little note. It's still on the alkalinic side. Okay? Normal alkalinic, but it's still alkalinic. All right? Now let's look at our CO2. Our CO2 is 50. Acidotic, normal, or alkalinic? Acidotic, 50 is way on up there, right? Okay. And then our bicarb is 34. Acidotic, normal, or alkalinic? It's still alkalinic. Okay. So now to determine where the problem is, you still got to look and see which side the pH is closer to. Well, in this case, the pH is still lining up with the bicarb, so we know the problem was still metabolic. Okay. And the pH is on the alkalinic side. So we still would put down our metabolic alkalosis. Okay? All right. Now when we're looking for our compensation, yeah, it's not alkalinic anymore, but it's still on that side. So we can interpret that the problem has occurred and has been fully compensated, because the CO2 moved to bring the pH back down. So this is fully compensated. Metabolic alkalosis. Okay? Does that make sense? All right. Does anybody still kind of... Go ahead. Sure. Yeah, and it's easier as you're following it along, and you can look at the different values, kind of like we did. We just kind of followed that along. When you're coming in fresh and you haven't seen that change, it's a little tougher. That's the only reason I'm throwing in. You got to figure out where the problem was, because it's not there now, but there was an issue if the CO2 and bicarb levels are off. And if they're in the abnormal ranges, at some point the pH was off. Okay? Does that make sense? I don't know if I described that exactly like I had in my mind, but okay. The key, number one, and use this, if you just have to sit down at your test and put this chart on your scrap piece of paper, that's fine, okay? But you got to make them line up. Remember, 2 in a row is what you need, okay? You got to make the pH line up with something. Even if it's normal, you kind of need to look at the pH and determine if the other two numbers are abnormal, then the pH has been corrected. Okay? That makes sense. Any other questions? And we've got a whole nother group of slides. We're going to do this a couple times because I know this is complicated. And it took me forever to kind of figure it out, especially figure out how to teach it or hopefully teach it. I don't know if I taught it or not, but at least describe it. But you got 3 steps. Figure out alkalosis versus acidosis, then figure out what the problem is, metabolic or respiratory, and then figure out if there's an issue, or I'm sorry, if there's a compensation that's occurred. Okay? The key, though, is even though your pH is normal, if the other 2 are not, then something was wrong. There was some issue that has been corrected. Does that make sense? 'Cause, I mean, and then eventually stuff will start getting back into normal. But, all right. Y'all aren't ready to throw stuff at me yet, are you? All right. This is a tough concept you just have to kind of work on. All right. Yeah. Not to that level. I don't. I mean, because this would be if your CO2 levels are. They're not going to get that far out of whack. That there's going to be. Yeah. This is usually. Well, it could have been an acute or chronic issue, but usually there's some significant problems that are going on for the pH to start really being altered. So 7.40, okay. Well, they've really compensated. That's as fully it's not going to get to that point usually. Because, and I know this is tough because we haven't really got into why these things occur. Some of the respiratory conditions that cause this, or some of the metabolic conditions that cause this. It's usually not going to get back that good. That's like perfect compensation, and that's usually not going to be that accurate. Let's see. But we'll talk about a lot. The way the respiratory system alters pH, we've kind of discussed. Anything that increases your CO2 level to a significant range outside of the normal limit is going to bring your pH outside of that normal limit, unless the bicarb is able to correct it. All right, any other questions before we move on to something else? All right. All right, so that knocked out our ABG stuff. And again, we've got a whole other slide presentation stuff on these alterations, but we'll get into that later. All right, so now let's talk about some more diagnostic tests. The pulmonary function testing. It's a non-invasive test that evaluates lung function and breathing problems. PFTs evaluate lung volumes and capacities, flow rates, diffusion capacity, gas exchange, airway resistance, and then also distribution and ventilation. PFTs can be performed at the bedside or in the respiratory lab by a respiratory therapist or respiratory technician. And the patient's going to be asked to breathe only through their mouth, through an actual mouthpiece through their mouth, allowing for the collection of various evaluation points. Okay, these are really, really good, especially when you're talking about asthmatics, patients with COPD. This really evaluates and puts numbers on how well this patient is breathing. Okay, how effective their breathing process is. Especially asthmatics, but you're talking about patients with allergic type issues, allergies, seasonal allergies, COPD, all these different things alter your ability to expand and bring in air and exhale air. Okay, very, very important. Now, some things to remember. If you've got a patient scheduled for a pulmonary function test, they do not need to smoke, okay, 6 to 8 hours prior to the test. Yeah, it's tough. Challenge. You got to encourage it. It's going to alter the actual test. Sometimes the physicians will have us hold certain bronchodilators, certain medications that would improve their function to see just how bad it is. Be aware of that. But that still needs to be by doctor's order. You don't hold it unless you've got a specific order, and it may be that there's a standing order. But you've got to have some kind of order that tells you to withhold medication at any point. All right. Now, and that's usually 4 to 6 hours prior to the procedure. and may hold the bronchodilators. Okay, next test we'll look at is capnometry and capnography. All right, this is an evaluation of CO2 as well. Now that's not looking at arterial CO2, but it's looking at the exhaled CO2 and the amounts. Capnometry is a method of measuring CO2 that evaluates a sample of exhaled air with a sensor that converts the reading into a color or number for analysis. Capnography, CO2 level is graphed as a specific waveform. The normal pressure of a Petco, or end-tidal CO2, so exhaled CO2 air, is between 20 and 40 millimeters of mercury. Okay. Now, don't confuse these with arterial CO2. This is different. This is a different measurement. It's still looking at CO2 levels, but it's a different measurement. All right. This is a less invasive way of evaluating. All right, some other non-invasive tests, exercise testing. This is stress test. Okay, go in and have them run on a treadmill or walk on a treadmill. Evaluation of activity tolerance. Okay, really, really important for a patient with severe dyspnea prior to discharge. We want to understand and kind of have a good evaluation of how well are they going to function in different activity types before they go home and fall out on the driveway trying to walk to the mailbox. Okay. Another thing that will evaluate that, really it's exercise testing as well as physical therapy. You'll go to the hospital and you'll see some of these COPD and patients that have come in with exacerbations. They'll be walking them. All right. Yeah, it's good for them, but we also it helps us to evaluate their activity levels and tolerance. Skin testing is another one. Skin testing allows us. Does anybody have a lot of allergies? If you've got a lot of allergies, you probably are aware of this. They go in sometimes and they'll do different skin tests and evaluate the different allergies that they can do. What is it, like 100 injections or, yeah. I know they've got the grids and things like that they can do, but it seems kind of tough. But anyway, it's used to identify allergies in various infectious diseases, viral diseases, and also fungal diseases. Okay. And I know we're kind of going through this in a hurry, but I'd like to get through some of it. Some of the other invasive diagnostic testing, endoscopy. Okay, what's an endoscopy? Take a scope and they evaluate on the inside, right? Just a long camera. They put it down through the respiratory tract, evaluating different respiratory system parts, all right, or aspects of the respiratory system. There's different types of endoscopies. First one you got is a bronchoscopy. Now, one thing to remember on a bronchoscopy, they may or may not use it's a lidocaine, benzocaine spray. It's to help to numb the area. If they do use that, it's important to remember the patient could suffer from what's called methemoglobinemia. Okay, methemoglobinemia is when basically the particles of that, the benzocaine spray can go in and bind to the hemoglobin and convert it to an unstable or unusable state. Sorry. Say it again. Oh, okay. Yes. Methemoglobinemia. So METHMOGLOBINEMIA. Methemoglobinemia. So it converts the hemoglobin to an unusable state. So if hemoglobin is not in a usable state, what happens? What is the usable state of hemoglobin? Bind to oxygen and carry it to the cells, right? So an unusable state is a big problem. Okay. So it results in what? Well, and usually it's not 100% binding to 100% of the hemoglobin, but it does could result in tissue death, hypoxia. Okay, hypoxia or deprivation of oxygen to the tissues. All right, so our treatment for that. Well, we got to give them some supplemental oxygen to increase that percentage, but also there's an antidote. Methylene blue. Methylene blue is an injection we can give, and it basically turns the hemoglobin back or counteracts the effects of the methemoglobinemia. And this is kind of a, I don't know the prevalence, but if you've got a patient that's gone down for endoscopy and they're really struggling to breathe afterwards, the big thing is recognize that that's an issue. Okay, a patient went down for a bronch or even stayed at the bedside and they did a bronchoscopy, and now they're having trouble breathing. Well, we need to figure out what the problem is. Call the physician. Let them know that there's some problems going on. Okay. In most cases, if you've got a patient with an endoscopy or bronchoscopy, you're going to have some oxygen there, right? You should have it prepared and ready. In most cases, you're going to have an order, or you can get an order. So you walk in, the patient's post-procedure from a bronchoscopy, and they're struggling to breathe, get them some oxygen, and then let the physician know. Okay? Just recognize it as an abnormal. That's a major issue. All right. The laryngoscopy is visualization of the larynx, so the vocal cords, the structures that involve speech. They can go in and they can take a look at them. They can also obtain tissue samples, do a biopsy, scope, whatever. They can do a lot of things. I think this is kind of what Joan Rivers had a couple weeks ago, I believe. Yeah, she went in for the laryngoscopy. So these are dangerous type procedures. Yeah, they're, you hear that there's no routine surgery. Well, there's really not. I mean, there's things and complications that can occur. You as a nurse, it's your responsibility to be able to recognize those problems before they get to the point where there's, we're at the point of no return. Okay. And then finally, the mediastinoscopy is insertion of a flexible tube into the chest wall above the sternum. Okay, it's above the sternum and between the lungs, and it allows for visualization of the structures, for tumors, or to obtain tissue samples. So it's just a flexible catheter above the sternum and then between the lungs. Okay, so you're going to go in, and it's just a camera on the end of a tube, I guess. But that's kind of what these are just different diagnostic tests that they can use, and these are highly invasive, you can tell there. All right. Now, before an endoscopy, patient should be NPO 4 to 8 hours because, you tell me, what's the risk? What's the problem that aspiration? And that's the same with any procedure. The risk of aspiration, is pretty good. So we want to make sure we reduce that risk. So if they don't have anything in any stomach contents, they don't have anything to aspirate, at least in theory. And then finally, we've got a thoracentesis here. Okay, thoracentesis, stick a long needle in and pull off some fluid. Okay, the aspiration of pleural fluid from the pleural space. Now, what's the pleural space? It's kind of on the outside of the lungs, right? It's not just one layer on the outside of the lungs. We've got a multi-layer. It's the pleural space. Okay, the pleural surrounds the chest, the lung cavity, or not lung cavity, but the lung structure there. The thoracentesis goes inside that pleural space and pulls off fluid. So if you have a buildup of fluid, or they just want to test the fluid, they can do that as well. Now, the important thing here, they need to be positioned correctly. Okay, and this is the proper positioning if you can get them in this position. Sometimes you can't get them in that position, but you want them sitting up, arms over a bedside table or something to support them, similar to an epidural. I know y'all are in OB at the same time, some of you. Similar positioning. Now, are all of your patients going to be able to sit up like this? No. How do you think we would position a patient that couldn't sit up like this? Okay. We're going to position them on their side with basically the lung that we're wanting the physician wants to go into up. Okay, so that's the side that would be up, so that they can go in. Now, what do you think the danger is? See this big long needle here? What's the big danger here? Puncturing the lung. Yeah. What if they miss with that needle? They don't hit their landmark. For one, we have to make sure they're perfectly still, make sure they're positioned correctly. But two, know what you need to look for following the procedure. Okay? Following a thoracentesis, we're looking for signs that they punctured a lung. Okay? What's the medical term for puncturing a lung? Do I remember that or know it? Anybody? Pneumothorax. There you go. Pneumothorax or collapsed lung. Okay. All right. And they'll also, along these same lines, they can also do lung biopsies. It's going to be similar positioning. Just depends on where it is. This is an investigative test used to obtain lung tissue for histologic analysis, culture, or cytologic examination. It may be performed in the patient's room as well. They're more commonly done in the OR, but if a physician really wants to do it, they can do it at the bedside. Following a procedure, same monitoring is going to go on. You're going to monitor for pneumothorax, assess vital signs, breath sounds at least every 4 hours for 24 hours. One of the distinguishing characteristics here, a thoracentesis, they'll do it at the bedside and then they'll send them home. This can kind of be done as an outpatient procedure. A lung biopsy, they usually want them to stay over 24 hours. Or maybe, probably 23 hours. Probably don't want them to do 24 hours, but they'll usually keep them overnight and evaluate. Assess for signs of respiratory distress and report any reduced or absent breath sounds immediately. And then also monitor for hemoptysis. Anybody have an idea what hemoptysis is? What is heme? Blood. All right. Optosis. What do you think it might be? Good guess. Blood in the lungs, which is going to come out where? Sputum. Hemoptysis is bloody sputum. Okay? So blood in the sputum. All right. All right, so these are the big, and you need to know this, okay, signs of pneumothorax, okay? Both of these procedures can cause pneumothorax. You need to be aware. Pneumothorax, you're going to see pain on the affected side that's worse at the end of inhalation. So when they breathe in, it's going to really hurt, than at the end of exhalation. Rapid heart rate, rapid shallow respirations, feeling of air hunger, prominence of the affected side that does not move in and out with respiratory effort. So, by unilateral movement during inspiration, one side does not move at all. Okay, one side's not moving with respiration. One side you don't see any inspiration and expiration going on at all. The trachea will slant more to the affected side, or the unaffected side. Okay, and you'll see. I think we've got a picture here in a minute. But everything shifts. The mediastinal shift will occur. You've got a collapsed lung on the right. Everything kind of shifts over to the left. All right. It's got to do with the pressures, I think. I'm pretty sure it's got to do with those pressure shifts. But again, that's just a guess. So don't write that in your textbook yet. Yeah. And then new onset nagging cough is a huge one. And then finally cyanosis. Okay. Now, if the patient has gone through these either as an outpatient or they've been discharged after 23 hours, usually this is going to occur before that. But they need to be educated on the signs of a pneumothorax. Okay. They need to know, if I have pneumothorax, I need to call a physician. Well, not even that. I probably need to go to the ER immediately, because that means that a lung has collapsed. All right. All right. I think that's all I'm going to do today. I know y'all are tired and ready to go, but good luck on your test.